All right, so today we're going to be covering plantar fasciitis. A lot of people tend to suffer from this type of pathology. It's kind of that pain in the foot, but we're going to really go over what it is, how to diagnose it, what are the issues associated with it, and we'll even give you a simple case of what someone may present with. So here's an example of a typical presentation someone may have. So here we have a 38-year-old female who complains of frequent sharp and burning pain in the bottom of both feet. Pain is usually, it started around 6 to 7 months ago. VAS stands for Visual Analog Scale. So 10 being the worst pain you've ever had, 1 nothing at all. She's got about an 8 out of 10, so it's pretty flared up. She began an intense training program 5 days a week, 7 months ago. So she's trying to get into whatever sport she's doing, whatever fitness it is, depending on what it is, or just a typical. She began an intense training program, usually around 5 days per week, which began around 7 months ago. So whether it's for some sport that she's doing, whether she wants to get fit, weight, or whatever it is that she needs to do, but now she has these issues. So the patient is on her feet most of the day, and the pain is usually worse at night. So one of the most common causes of heel pain is plantar fasciitis, usually caused by inflammation to the plantar fascia. So here's some kind of interesting statistics for you. So approximately 1% of the US adults reported a diagnosis of plantar fasciitis in the last year. Females were 2.5 times more likely to have plantar fasciitis than males. Body mass index was strongly associated with plantar fasciitis. So those with a body mass index of 30 or more were around 5 times more likely to have plantar fasciitis. Another statistic is that more than 61% reported having pain every day. So more than 61% reported having pain every day, and almost 54% reported that their pain interfered with normal work activities, at least moderately. So it's not only at work that this can be an issue. This can be going home, this could be doing your gardening, this could be walking around, just even going to the gym, or even getting in and out of your car at the beginning of your day. This is one of those issues that can cause a debilitating injury or can affect your day-to-day in a negative way. So here's kind of a diagram showing the connective tissue. So the plantar fascia is a connective tissue or aponeurosis. It supports the arch of the bottom. This supports the bottom arch of the foot or the plantar side. It runs from the calcaneal tuberosity, kind of this issue right here, as you can see. So the plantar fascia is a connective tissue aponeurosis. It tends to run from the bottom of the foot or the plantar side. It runs from the calcaneal tuberosity. So here's the calcaneus, here's the actual tuberosity. Tuberosity just means that point of bone that sticks out and is attachment site for the connective tissue in this area. And it runs from the calcaneal tuberosity to the heads of all the metatarsal bones. It's a long, pretty thick band, and it does support the bottom arch of the foot pretty well. So when this flares up, that's why people tend to have pain all along this area here. A little side note is that research indicates that the plantar fascia is not actually fascia, rather it's an aponeurosis. So kind of going over what that means is that fascia is that fibrous tissue that envelops muscles, organs, or binds muscles together in other tissues, and aponeurosis can act as a fascia. So this is kind of that idea, all squares are rectangles, but not all rectangles are squares. So here we kind of got a diagram with the anatomy kind of dissected away. So the aponeurosis is a white flattened or ribbon-like tendon expansion serving mainly to connect a muscle with the parts that it moves. The plantar fascia is made up of predominantly longitudinally oriented collagen fibers. There are 3 distinct structures or components: the medial component, then we have the central component, and then we have the lateral component. So you can kind of see we have the medial component here, central component here, and then we have the lateral component here. The central component is the largest and most prominent. So you can kind of see it coming here as it comes from the whole part of the foot, as we said, from the calcaneal tuberosity to the base of the metatarsal bones. So as we can see that the origin of the plantar fascia is at the medial process of the calcaneal tuberosity. You can kind of see it here. So there's kind of the lateral view. You can kind of see the anterior talar articular surface, and then here's the other side of it here. So we won't go too much into it there. The plantar fascia inserts towards the front of the foot, dividing at the mid-metatarsals into 5 sections, each extending into the toe, straddling the flexor tendons. During walking, the plantar aponeurosis functions mainly during heel rise or toe off. So kind of as you kind of lift up and kind of walk forward, lift up and walk forward. So as you kind of go here, here. This allows it to stabilize the arch of the foot and allows flexion of the first metatarsal, which is kind of the first bone there, enabling the first metatarsal to carry the majority of the body weight. As you kind of come here, there you go. You kind of come here, there you go. It also provides shock absorption when the foot hits the ground. So you can kind of see that it's a very dynamic aponeurosis or connective tissue area that allows for all the dynamic movement, stability, flexibility, and mobility of your foot. So we are animals that kind of walk every day and kind of get moving all the time. So this is really one of those things that if it is bothering you, it's going to be a problem in your day-to-day. So let's go over kind of the typical presentation of plantar fasciitis. So the history has usually usually some sort of intense, sharp heel pain with the first couple of steps in the morning or after long periods without bearing weight. So, you know, sitting down for a long time, driving for a while, if you got to commute to work. So for those first couple steps is going to be an issue until you actually get that plantar fascia moving. Often the pain will decrease significantly. Often the pain will decrease significantly with ambulation or athletic warm-up, but tends to increase throughout the day as activity increases. So as you begin to move it, it kind of gets unstuck, gets moving, but then as you move it a lot more throughout the day or through your walking, or if you're moving a lot on your feet, then it tends to get a lot worse in the evening. And in some severe cases, patients can complain of heel pain after long periods of prolonged sitting. So as we said before, so kind of a typical presentation is that it'll tend to bother individuals so much that they will stop doing what bothers them. You know, so if that's walking, in this case it was someone who's working out, starting an intense regimen for exercise, whether it's weight loss or for some sort of competition or sports training event or some sort of marathon. Now they have to stop doing what they enjoy doing, when that's kind of where the issue begins. So here we have the patient's foot pain has been significant enough that she has stopped all exercise. Over the past several months, she has undergone treatment with a podiatrist who recommended x-rays and a custom orthotic. So something going into the radiology about it is that plain film x-rays are often not obtained for plantar fasciitis. However, the diagnosis of plantar fasciitis is not made off an x-ray. So typically people will get an x-ray of their foot. Let's say, for example, we've all seen that 12-year-old kid jump off the roof doing something stupid, or jumping off the trampoline and they roll their ankle. Then when we suspect, so we've all seen the example of that 12-year-old kid who's jumping off the roof, rolls his ankle, or jumps off a trampoline and falls and hits the ground really hard. So we'll do an x-ray report most likely, or most of the time, on a foot pathology if we suspect a fracture or something else, thing like, let's say, arthritis, rheumatoid arthritis, or psoriatic arthritis, or just depending on what we suspect is going on. Usually if it's a soft tissue anomaly, it won't warrant an x-ray, but the diagnosis can be made with a combination of a patient history and physical examination. So x-rays may be able to identify contributing elements such as a heel spur, or in some cases when they're running a lot, a stress fracture. And those will be the typical events when we will get a x-ray, because it does warrant, or the radiology report, to be able to see that. So here we got some x-rays and we kind of see an actual heel spur there. So the arrows nice and pointing to it. So now let's kind of go about what those custom orthotics that were prescribed. And these can be from either your podiatrist or something as simple as foot levelers as well. So kind of going over some studies here. So kind of what these studies have found is that prefabricated and custom made. So kind of showing what the study has shown is that prefabricated and custom made foot orthotics are effective in reducing heel pain and improving foot function in patients with plantar fasciitis. So here's kind of just a look at some of them. Some of them tend to be, you know, you can kind of place your foot in them. Some of them are already pre-made, and then some of them are molded to the actual foot, just depending on what it is. With foot levelers, they do kind of like a scan at the bottom of the foot, and it's kind of recommends the most optimal prefabricated, in a way, orthotic that's made for your foot. So they have hundreds of them for different types of feet, different types of arches, so whichever one is the best fit for you. So most of the time, if someone goes, they'll get some sort corticosteroid shot or cortisone shots, anti-inflammatory medication and orthotics, sometimes even deep heat laser therapy. So you need to be mindful that cortisone shots will get rid of the pain, but too many of them will weaken the tendon and cause rupture of either the muscle bellies or the other areas of connective tissue that are there. So generally more than 2 is when it becomes an issue. So we don't even want to go down that road. It kind of be that last lifeline for you to use if the pain is that severe or you're not getting any relief from anything else. So make sure that you exhaust all your conservative care treatment modalities, whether it be soft tissue work, deep heat laser therapy, even something as acupuncture, manipulation of the foot, see if there's anything going on with the mechanics of your foot, if there's going to be an issue with it. So just keep that in mind. So kind of coming back to our case here, the patient's pain has been ongoing. She presents for chiropractic with ongoing symptoms or complaints. So we needed a more detailed history, specifically showing finds that she has been working out 5 times a week, doing jumping, sprinting, and lifting exercise. She spends several hours a day on her feet and often carrying her children. So let's kind of go over some of the risk factors here. So excessive foot pronation or pes planus, excessive running, so kind of causing more prevalence of heel spurs or even stress fractures, a high arch, leg length discrepancy, obesity is one of the big ones, prolonged standing or walking occupations, great one would be military personnel, a sedentary lifestyle, tightness of the Achilles tendon and intrinsic foot muscles. So one thing that people don't stretch out a lot specifically is their calves, or work the antagonist of it, which is the tibialis anterior. It's the muscle kind of sits on the front where your shin is. So if you flex your foot up like this, you'll feel it on the front side of your foot, or on your shin, I'm sorry. And that one is the one that kind of stops the movement. So those muscles need to be worked in a way that allow for foot stabilization as well. So in some cases, patients may walk with their affected foot in an equine position to avoid placing pressure on the painful heel. So kind of what an equine position is, if we kind of take a look at it, we can kind of see, here's horse, right? Kind of placing their foot there to avoid putting pressure on the actual bottom of the heel. So palpation of the medial plantar calcaneal region will elicit a sharp stabbing pain. So passive ankle or first toe dorsiflexion, kind of moving the toe towards your nose, or the big toe towards your nose, can cause discomfort in the proximal plantar fascia, so kind of in that area over here. So kind of we're flexing that tendon back, as we know that it runs kind of like that. So as we flex the big toe towards your nose, it'll cause a little bit pain there, or just some discomfort. It can also assess tightness of the Achilles tendon if this is an issue as well. Some differentials to be on the lookout for, specifically with plantar fasciitis, such as like nerve entrapment, neuropathy, tarsal tunnel syndrome, calcaneal fracture, Sever's disease, a stress fracture, and other issues like we talked about before, arthritis, plantar fascia rupture, and the list goes on and on. So we just got to keep that in mind as the practitioner that you're going to be going to does want to do a specific and in-depth differential to make sure that it's not something else, that it is plantar fasciitis. So kind of an example here, coming back to our example patient, is that the examination finds tenderness over the medial aspect of the calcaneus. There's also restriction with the calcaneal talar articulation and the tight spastic Achilles tendons with flattening of both arches of the feet. So as the feet kind of put pressure on them and the arches kind of go down and do their shock absorption mechanism, that's when they have pain. Kind of showing you, where the heck is this calcaneal talar articulation, and kind of see it as kind of coming over here. So there is some restriction with this movement because of the Achilles heel, or the Achilles tendon being tight, thus being the muscle being tight. So something else as well is we could see the bowing of the Achilles tendon. So most people don't get this snapshot of their feet from the back side. So overpronation of the foot leads to the bowing of the Achilles tendon, and the flattening of the arch may contribute to plantar fasciitis by putting additional strain on the plantar fascia. So as that fascia kind of spreads out and it's even being more pronated, it's kind of being stretched out more. So normal here versus pronated there. So something to take a look at as well is the way that your shoes wear. So this is one of the telltale signs. One of the things that you can take a look at as well is abnormal heel wear. So this is one of those ways that you can look at, make sure, are you having normal foot pronation, or are you having overpronated feet? So you can kind of see that we have the new heels kind of there, then we have the worn heels to the side, and kind of see that they're being worn out because that foot is being overpronated or underpronated as well. You can kind of see what part of the foot shows pronation and overpronation. So overpronated being the middle side of the foot or the shoe, and then underpronation would be on the other side there. So you can kind of see different types of shoes, different issues. So kind of going over the foot is kind of the distal area where we'll see things show up if there's other areas having issues as well. So one thing that chiropractic care will usually try to do is try to correct the pelvis and the mechanics behind the pelvis as well, or even the lumbar spine. So in our fake patient here, we have the patient's pelvis showed kind of misalignment is a term, but issues at the L5 to S1 joint and the right sacroiliac joint. So hip joint motion was in full and pain-free with no tenderness over the greater trochanter. The ischial tuberosity, it's kind of that bony part of your butt when you sit, when you were a kid and you sat on someone's lap and they say you got a bony butt, that's the part that's poking into their legs. The ischial tuberosity or sciatic notch. So muscular tightness was noted in both hamstrings, which is a big thing. She is working out a lot. She is exercising more. Most people do not stretch, and this is one of those things that we covered previously. That's why it's so important to make sure that you're stretching all the time. Not only is it great for maintaining the level of activity that you have, but also preventing injuries, which can lead to other issues as well. So we know that tight hamstrings, dime a dozen. Most people have them. So we know that that causes other issues with hip movement, which translates down the knee. The knee's not, it's a really stable joint. It's a really powerful joint. It's not going to be the first one to go. The main issue is going to be the plantar fasciitis. So kind of going down that kinematic chain, hips aren't moving because of the tight hamstrings. Hips are strong. Knees are strong. Now we got this piece of fascia down at the bottom of the chain that might be an issue. So we got our working diagnosis right with this patient, which are plantar fasciitis. So let's kind of cover the types of treatment that are available for plantar fasciitis. So manipulation of the calcaneal talar joint, ice massage, stretching and soft tissue techniques, and this can be anything from Graston or gua sha, whatever name that people decide to use or are familiar with. Acetaminophen or NSAIDs, we try to stay away from those just because they do cause a higher prevalence of gastric ulcers as well as liver issues as well. Being mindful if you are taking aspirin or any type of non-steroidal anti-inflammatory drug, a great alternative for that would be turmeric or curcumin. It works in the same inhibitory pathway for pain as aspirin, so it works on those COX receptors as well. COX. Heel cups, full length custom orthotics. So those are the things we kind of covered before, working on that movement of the mechanical framework of the foot, supporting it in the proper way, because some people just have overpronated or underpronated feet. So that foot leveler scan would be very imperative to have. Weight loss would be a great one. It takes that pressure off the foot. So this is one thing that people see a lot as they're going through their exercise journey and they're starting to lose weight. They're starting to have issues with their feet. This stops them from exercising, thus continuing on their weight loss journey. So now they can't do the things that they want to do. They can't do what they need to do. And now they're just kind of being inhibited by the things they were trying to get done before. Specific exercises, maybe like flexion or extension exercises of the foot, such as working on the tibialis anterior or even working on calf work as well. Iontophoresis, myofascial work, kind of working on the actual fascia of the foot, or the aponeurosis as we call it now. Prolotherapy or dry needling, corticosteroid or PCP injection, and last ditch effort, and an anterior night splint. So this is one of those things that it's one of the best options. It's pretty much just a boot, it's pretty much just a boot, but who the heck's gonna wear a boot to bed? I know that that's not feasible, it's not comfortable. It is one of the best things because it keeps the fascia flexed and extended for prolonged periods of time, but it's not gonna be something that has high patient compliance as well. And then in worst case scenarios, some people do tend to get plantar fasciotomies where they remove the plantar fascia. We don't recommend this. It just tends to be one of those things that it is performed, so I kind of put them in there to make sure that these are options that people have. So as we shown before, eccentric stretches, heel cups or custom orthotics, and then there's that anterior night splint, which most people, I wouldn't wear it. Most people wouldn't wear it. Let's be honest, that thing's not comfortable to sleep with as well. One thing that you can avoid doing though is that one thing that I thought about was it causes issues when it's flexed for prolonged periods of time. So if you are a stomach sleeper, you want to make sure that you're trying to get out of that habit and try sleeping on your side, because having your foot kind of extended on the bed as you're laying down is going to flex that fascia, and it is going to be tighter when you wake up. So if you are a stomach sleeper and you are suffering from plantar fascia, make sure to try these different little tricks and see if it does help you out. Again, on those eccentric stretches, so making sure that you're doing, calf raises, just one of those things that's kind of most people tend to neglect. So kind of what we recommend for our fake patient here would be foot flexion, extension, toe stretches, towel stretches, kind of pulling it on the toe, calf raises, exercises, mobility, and training behind it. I know that was a lot of information. Trying something new here, going over with our fake patients, kind of show what similar presentations would be from certain individuals suffering from plantar fasciitis. We want to make sure that we give you the best information, kind of go over what the treatment plan is, what it is that we're treating, what's the common anatomy in the area, how you can kind of go over it. And I hope this video was helpful and informative. And if you did find that to be helpful and informative, please follow, subscribe, share, and like, as it is the best way to support our channels. Thank you and have a wonderful day.